Well, good morning, everyone. Happy Veterans Day to all our service people online today and family of those. We hope you're having a great month. Welcome to Trio Maryland's November Zoom meeting. It's great to see everyone. I'm Marty Marin, and this is my wife, Michelle, and we manage Trio Maryland. Today, Michelle's doing it on one leg because she just had her one knee replaced last Friday, so thank God I have some help. We'd like to welcome all our members and guests this morning and thank you for attending. Today's topic, understanding medications and insurance options for transplant. It's a great information to help us with and help us make an informed decision about our decisions that we have to make with our new programs. There is not a Zoom speaker in December, so we hope you enjoy your holiday with your friends and family. And January, there will be an in-person meeting, so stop by if you happen to be in Baltimore. Otherwise, we will see you in February for our next Zoom meeting. Today's topic is being presented by a very good friend of ours, Ian Booth from the University of Maryland. And once again, here is my wife to introduce the speaker.
Good morning, everyone. Nice sunny day. Before we get started, we have a few housekeeping notes. Please type your questions into the chat feature of Zoom, and they'll be answered at the end of the presentation or during the presentation if they have not been addressed. Everyone should be muted, but please mute yourself if you find that you are not. Thank you for your help. This presentation is being recorded and will be available on the Trio Maryland YouTube channel in about a week. I will send you an email via Eventbrite with the link to this presentation once it is available after editing. Today's guest speaker is a fan favorite, Ian Booth, a solid organ transplant clinical pharmacy specialist. Ian is originally from Jackson, New Jersey. He completed a Bachelor's of Science in Chemistry at Westchester University of Pennsylvania and a doctorate of pharmacy at Temple University School of Pharmacy. He completed 2 years of pharmacy residency training, including 1 year of solid organ transplant specific training at the University of Maryland Medical Center. Ian now practices as a solid organ transplant clinical pharmacy specialist at the University of Maryland Medical Center and also serves as an assistant professor at the University of Maryland School of Pharmacy. We're very lucky to have Ian back again to educate us with all this information. Thank you so much for presenting to our group. Welcome, and I now turn the program over to you.
All right. Good morning, everyone. And Michelle, Marty, thanks again for the introduction and for asking me to present again to Trio. It's definitely a pleasure of mine to be here with everyone today, and hopefully I can give everyone some information about some transplant medications and some insurance specifics. And I'm going to talk a lot about various different insurance options today. And I was explaining to Michelle and Marty earlier is that I'm happy that this is recorded and that there's an opportunity to review this on the back end as well, because the way I set this up was I wanted to provide as much information that can be referred back to if you have questions. Now, because there's so many different insurance options available to patients, I tried to be as specific as possible without getting too into the nitty-gritty of everything, because it can change from patient to patient. But my hope was that this was available for patients to be able to look back on and refer to if they have questions. I will say that I encourage everyone to ask questions, and I'll pause throughout if there's any urgent questions that you want to ask. And if you want to put some questions in the chat for us to go through at the end, there'll be plenty of time for that. The one thing I will say is that I am by no means an insurance expert. I am a transplant medication expert. And so I can definitely answer questions to that. And I do go through a few medications just to highlight some of the basics of what you'll be on after transplant. As a pharmacist, I couldn't leave that information out today. But when it comes to the insurance options, I have a lot of people that I work with that help me with making some of those decisions. And so if I can't answer your question, I will be sure to write some of the questions down, and I can try to get back to Michelle and Marty to post that on the website as well with some answers, because I want to make sure that I provide as many answers as I can if I can't answer them myself. So again, I will go ahead and get started. So the topics that we're going to cover for today are to describe some of the common medications that we use to prevent rejection and infections, just as an overview for some patients, whether this is new information or old. Then we'll go through some basics of health insurance and coverage, and then compare and contrast some of the different insurance options that are available to patients. And again, I'm going to highlight some of the more broad categories of insurance options that are available. So we'll first start with that first topic, and we're going to go through some of the common immunosuppressants. So you'll hear immunosuppressants or anti-rejection medications used interchangeably throughout your course. And these are the medications that we use to prevent rejection after transplant. So we want that new organ, no matter what type of organ it is, kidney, heart, lung, doesn't matter. We want to prevent our body from rejecting that new organ. And these are the types of medications that we use. And while I'm not going to go into specifics for today's presentation, I'm sure that there is a presentation available from back in January or February when I last spoke to Trio, when I went into more details about these medications. So if you have questions about those, I'm sure that's available as well. But we break these medications up into a variety of different classes, and we use multiple different medications from different classes to prevent rejection. So the most important medication are your calcineurin inhibitors, such as tacrolimus or cyclosporin. So you may be on some of those. Antiproliferatives, such as mycophenolate or azathioprine, and then steroids commonly used, prednisone, and then some variety of other medications that are on the bottom there as well that also can be used depending on where you are in terms of your time from transplant. So these are things like mTOR inhibitors like sirolimus and everolimus, and then an IV medication that some patients are transitioned to, which is called belatacept, which is one of our newer medications that are used. So again, there's a variety of different regimens that are used depending on where you're transplanted and the time from transplant. But these are the most common ones that are used at most centers. And so why do we use immunosuppression in general? So you can see in this graph, you can see on the left-hand side, it's a percentage going from 0 on the bottom to 100 on the left, and then the years from 1960 all the way up to 2005. And what I wanted to point out here is that these medications that we use have prevented this rejection that I was talking about. So in that gray line, you can see that the rejection risk is lower as we've developed these newer medications. And then in the black line, patients are now surviving longer. So this is a win-win in terms of preventing rejection and keeping our patients alive longer with the development of these newer medications, such as tacrolimus or everolimus on that right-hand side, which really haven't been developed for more than about 20 years or so. So really haven't been around that long. And this is where transplant is a fairly newer concept, and these medications are still being developed today. There's a lot of things that we have to consider when we're discussing, what immunosuppressive medications patients should be on. So on the left-hand side, these are all factors that would potentially need more immunosuppression, where on the right-hand side, these are things that would potentially lead us to giving the patient a little bit less immunosuppression. So some things to highlight on the left-hand side there, if you're a little bit younger, African-American patients, if you have a history of HIV or human immunodeficiency virus, or if you've had a history of a prior organ transplant or have had rejection in the past. These are all things that may lead your transplant team to increase your immunosuppression to prevent rejection a little bit more. Where on the other side, if you're a little bit older in age, if you have a history of any type of cancer or malignancy, or even any type of significant infection, these are all things that may lead us to decrease your immunosuppression to prevent any worsening of those symptoms or issues. So again, this is a balance as to how we manage the immunosuppression after transplant. And I'll talk a little bit more about a balance in a few slides. And then the other thing to highlight is that all organs are not created equal. So every organ does not require the same amount of immunosuppression. So you can see here, it's the timeline really of, on the left-hand side, these organs such as a small bowel or a lung transplant, these require the most immunosuppression because there's the highest risk of rejection. Compared to something like the kidney or the liver, these organs are less immunogenic, so they require less immunosuppression overall, and there's that lower risk of organ rejection. So again, all of these things need to be factored in terms of how we develop our regimens after transplant. And then here's that balance I was talking about. So we, on the left-hand side, are trying to balance, preventing rejection of the organ and prevent graft loss. So we want to keep these organs as healthy as possible for as long as possible. But we want to also balance the risk of side effects with these medications. So of course, as great as these medications are in preventing rejection, they also do come with a list of side effects that can happen. Again, I'm not going to go into details of what those side effects are today, but that information is available. But then also we want to prevent infection. If we give every patient just too much immunosuppression, that can cause infections or even malignancy. So all of this is a balance, and it's always a balance throughout the entire course of a transplant to prevent, all of these adverse effects or bad outcomes to happen, to make sure that the patient stays as healthy as possible. So what are the risks of infections after transplant, and why is there that increased risk that we need to worry about? And so really, when we're talking about anti-rejection medications, those medications are lowering your body's immune system so that it doesn't have the same ability to fight off this new organ. Well, what that does is that now that weakens your immune system to fight off infections like it used to. So patients after transplant are more likely to get infections, and also they'll show fewer signs and symptoms of an infection. So what I mean by that is, if prior to transplant you had an infection, your body is going to mount that immune response, and typically the first sign of that is a fever. After transplant, you may still become febrile or have a fever, but it may not be as high as what you're used to really show that you have that infection. So it really just kind of masks the signs of an infection when you're on these anti-rejection medications, which is why we have to be extra careful in making sure that we're being cognizant if we're starting to feel sick or have any other signs of an infection. And then it may take us a little bit longer to heal because our immune system doesn't have that same ability to kind of overcome the infection. So we give certain medications after transplant to prevent these certain types of infections when that risk is the highest. And I'm going to talk about 3 different types of infections for today, just as a basic kind of broad overview. So we worry about bacterial infections, viral infections, and fungal infections. And I'll go through each one of those briefly. So bacterial infections are fairly common depending on the type of organ transplant that you have received. But what we do is we give most patients what's something called sulfamethoxazole trimethoprim, or also called Bactrim, which you probably have heard of at some point. And this prevents a certain type of pneumonia that can happen. And then specifically in our kidney transplant patients, this can prevent urinary tract infections. The duration really depends on the type of organ that you've received and the transplant center that you are transplanted at, but typically ranges anywhere from 6 months to 12 months or even lifelong for certain populations. I listed some side effects there of the meds that we use and some alternatives that are also used, but really I wanted to highlight that there are bacterial infections that we worry about the most. The second one being viral infections. We commonly use something called valganciclovir or Valcite, and this is really to prevent what's called cytomegalovirus or CMV. You may have heard of that. The duration, again, depends on the type of organ transplant that you received and the risk status that you have in terms of if you've ever been exposed to CMV in the past. And then again, side effects and alternatives are listed there for you. And then lastly, fungal infections. So this is fairly common after transplant, given that we're giving you high doses of steroids at various times. And we use various different medications to prevent this, and again, dependent on the organ that you received. The most common one is the nystatin suspension that you swish and swallow. That's usually for about a month. But then there's other options like fluconazole or even voriconazole, again, depending on the organ that you received. And this is really to prevent thrush in your mouth or other types of fungal infections that can happen from getting the big operation that you just went through. So just a quick overview of all of those different medications. And meds that we use to prevent rejection and infection after transplant. I wanted to just briefly touch on that for today. Again, if you have any other questions about that or more specifics, we can make sure that the prior presentation that I gave back in February is available for your review. So now we'll move into some more of the insurance concepts. And I wanted to start off with just some very basic definitions to kind of set the stage for things that we'll talk about throughout the rest of the presentation. And so I have these all labeled as insurance terminology, and I'm going to just give you kind of a brief overview of things that you may hear throughout your course and just ways to kind of understand some of the terminology that's used. And I hope that this can be a reference for you to come back to if you have questions. So in no particular order, some of these concepts that I wanted to talk about. So the first is kind of that concept of in-network versus out-of-network. Now, every plan is going to be a little bit different in terms of what is considered in-network versus out-of-network. And that's really going to be kind of the highlight of today's presentation, is that really there are so many specifics to each plan that you really need to discuss this with your actual plan to find out what is going to be considered, perfect for you as your individual patient. So it's important to look into what doctors you're seeing in terms of if they're in network, because that's going to save the patients a little bit more money and usually have a little bit less to go through in terms of getting seen by these doctors versus an out-of-network doctor may be a little bit more expensive. You may have to get authorization to see them, and that can all depend depending on the plan that you've actually that you have. So an important concept just to look into whenever trying to make an appointment with a specific doctor. And then some other terminology that I have listed here. So you'll hear things called primary and secondary insurance. So your primary insurance is what's actually going to pay for your medical bills first. Then your secondary insurance is if you have a secondary insurance, and this is not a requirement, not everybody has a secondary insurance. This is really what's going to help kind of supplement some of that additional cost, if there is any, and they'll help pay for anything that's left over after the primary insurance has already paid. An explanation of benefits can sometimes be sent to you, or you can request this, and this is specific to prescription drugs, and this is going to give you kind of a summary of what your prescription drug claims and costs have been throughout the past year. And this can help kind of guide, where you are in terms of your plan. And I'll get into a little bit more in that later on, but it can give you an idea as to where you are in terms of your overall spending for the year. Out-of-pocket costs. So again, kind of that similar concept of, if you choose an in-network versus out-of-network, your costs may be a little bit different. So out-of-pocket costs are exactly what it sounds like. It's just expenses that you're paying, that are being paid for your medical care. That's going to be coming out of your pocket. And I have some examples on the next about some of those as well. So the first one's a premium. So you probably have heard of a monthly premium, and this is really what's paid every month for the coverage that you have for transplant. Then there's things called deductibles. So this is not a monthly amount. This is a yearly amount that's paid for the covered services before your plan begins paying. And then the copayment is just a fixed amount that's paid after the deductible is met. So kind of you can see how this is, each one kind of builds upon the next one. And then the co-insurance is just a percentage of the cost paid. So I know this is all just terminology right now, and I'm hoping that in a few slides when I talk a little bit later on, this will all come together a little bit as to how this all kind of works together in terms of your overall cost. And then specific to drug coverage, and this is again going to come up a little bit later on. I'm sure everyone has heard of the concept of donut hole, and I'm going to hopefully explain that in a way that makes sense to you in terms of why that's the case for certain plans. But what we'll go into is the coverage gap and the catastrophic coverage phases. So coverage gap is really what that donut hole, that inner part of the donut where there really just isn't any coverage. So this is where there's the time where your costs are a little bit higher until you reach that next phase or the next step in the donut, which we'll talk about, and that's the catastrophic coverage. So this automatically occurs once that out-of-pocket cost hits a certain amount. And then this is where patients are no longer responsible for their co-payments or co-insurances or any type of really payment for the rest of that year, and then until the year renews. So I have a better example of that a little bit later on, but I wanted to highlight some of those terminology now. And then lastly, just a few other things that you may hear throughout your course, a claim or denial. So a claim is really what we're requesting from the insurance company to pay for the service that you're receiving. So anytime time or a prescription is sent, they have to submit that to the insurance as a claim to see if the insurance will actually pay for that. Now, if the insurance denies it, that means that their decision is to withhold the payment for that claim. And then that may also kind of lead us to the last bullet point, which is the pre-authorization, pre-approval, or even a prior approval. So you may have heard some of those terminology thrown around, where that really what that means is that the insurance is request additional information in order to cover a specific service. So it may require your transplant team to reach out to the insurance specifically to kind of discuss some additional information and have them approve the coverage that is being requested. And that can kind of overcome some of those denials that may happen, or we can kind of beat the insurance to the denial before it even happens. And then formulary is the last one that I'll mention here today, as we'll talk a little bit more about drug formularies later on, is that this is really just a list of the drugs that insurance will pay for. So every insurance has a different formulary that they offer. And this is going to be important that we'll talk about in kind of figuring out what is going to be the best insurance plan for you based off the medications that you are on at this point, because not every patient is the same. Every transplant center, every organ is a little bit different in terms of what medications they will be on after transplant. We want to make sure that the formulary that is offered by the insurer is right for you. And that's the most important concept that there is. So we talked a little bit about the basics, and I wanted to just give that terminology because I'm hoping that that will set the stage as we talk about a little bit of the different insurance options that are available. And now I will say that I don't go through every insurance option that is available. I try to highlight kind of the bigger ones that I see on a day-to-day basis in my job. And so I apologize if I didn't specifically talk about the insurance option that you have, but we'll try to get through as much as we can in terms of kind of the basics. And then like I said, I can try to answer any questions at that point. So here's a kind of a group of different insurance types that are available, or different options. And this is by all means not an inclusive list. I'm sure I left some out, but I tried to highlight some of the bigger ones. So you have things like Medicare and Medicaid, which are obviously large insurance options with many different caveats, which we're going to talk about. You have things like COBRA, which is offered after potentially losing a job or kind of cutting back on hours. If you've recently retired, there's specific insurance that can be offered to retirees. There's federal employees and TRICARE for people that have served or work for a federal government. And then if you're a veteran, all types of options that are available. And then of course, there's private insurance, which is a laundry list of different options as well. But for the purposes of today, what I'm really going to try to do is highlight Medicare and Medicaid the most, as these are the most common, especially for our transplant patients. We'll talk a little bit about kind of the caveats between the two. And then also we'll talk about some of the different insurance options as well. I'll briefly talk about private insurance, but really for the basics of today, I think Medicare and Medicaid will be the most important to most of our patients. So we're going to talk about Medicare first, and this is going to be kind of the bulk of what we talk about for today. And I have just some general information as to what Medicare is. So Medicare is a federal health insurance that's offered to people that are 65 or older. Or if you're under 65, you have to have a specific other disability or condition to be qualified for Medicare coverage. So that's things like if you have end-stage renal disease, and that's what that ESRD is, and you require hemodialysis or transplant, or kidney transplant specifically, or if you have ALS as well. That's another condition that can kind of group you into Medicare, even if you're under 65 years old. This is run by CMS, or the Center for Medicare and Medicaid Services. And it's really the same no matter what state you live in. The same options are available no matter what state you live in, whether it's Maryland, Pennsylvania, Delaware, kind of anywhere in the tri-state area. All of the coverage is the same. There's just many different options for Medicare that you can achieve. Open enrollment is the same time each year, so October 15th through December 7th, which is actively going on right now. And then the changes go into effect January 1st of the following year. So that's important as we talk about the kind of the differences between some of them, where the coverage is the same in every state for Medicare. That is not going to be the case for some of our other programs that we'll talk about. And the open enrollment period is fairly different for some programs, but typically they're around this time every year and go into effect in January of the following year. So there is a little bit of a gap between when you pick your coverage and when that'll actually change. And there's 4 parts of Medicare that we'll talk about, and it's important to understand kind of the differences between each of them to know kind of where your coverage is coming from, and how you can best kind of clarify and find out what's going to be the best option for you. So the 4 parts of Medicare are A, B, C, and D, where A is your hospital insurance and care specific to hospital type care. Medical insurance, kind of everything else that isn't covered in A is typically covered under B, and I'll get into some of the specifics here for you. The Medicare C is something called Medicare Advantage plans, and then Medicare Part D is your prescription drug. So that's kind of the easy one, because D for drug, you can remember that that's the only easy one. The rest of them don't have as similar of a concept. So we'll talk about each of them individually here. So Medicare Part A is, again, your hospital insurance coverage. So this is things like if you're in the hospital, so inpatient hospital care, let's say at the time of transplant, or even if something happens after transplant that you need additional care for, this is going to come out of your Medicare Part A. This also covers things like a skilled nursing facility if you need to go somewhere after going out of the hospital, or even home health if you need a little bit of help kind of once you get home with managing various different things like wounds or IVs, things like that. This is all kind of covered under your Medicare Part A. Typically, patients don't pay a premium, and so this is called premium-free Part A, which is obviously kind of that same concept of that monthly amount that is paid for premiums. Medicare Part B is your medical. So medical obviously still sounds similar to what we just talked about, but medical services are a little bit different. So these are things more of like the outpatient care that you get. So if you're coming to a clinic or if you're going to see a different provider that's outside of the hospital, this is going to come out of Medicare Part B. Medicare Part B also covers mental health services and certain prescriptions. So the caveat to that, the certain prescriptions, this is very important for your transplant population, as all of the anti-rejection medications should be covered under Medicare Part B, which is very different than all the other medications, which we'll talk about that'll come out of Medicare Part D. So this is just the important point that I want to make, is that if you do have Medicare Part B, make sure that the pharmacies that you're using are able to and are billing Medicare Part B correctly. We have had times where we've found that patients use different pharmacies, which we obviously encourage patients to use whatever pharmacy is the best option for them. It doesn't have to be the pharmacy that's affiliated with the hospital. If it's a CVS or a local family pharmacy, that's perfectly fine. But we have found that there are certain pharmacies that don't have the ability to bill for Medicare Part B for anti-rejection medications, which is going to increase the cost that you're paying for them. So just a caveat to make sure that you're kind of doing your investigation kind of on your own and talking to your pharmacy and your local pharmacist to make sure that these are being billed correctly. If they can't bill Medicare Part B, just make sure you let your transplant team know, and we can try to triage that appropriately. The important concept, though, is that Part B is also optional. So not every patient will have this. You have to kind of decipher based off the plan that you have to determine if you actually do have it. Now, Medicare Part B, there is a premium that you pay, and this will depend on kind of what your income is in your family and in your household, and then it can change each year kind of depending on how things have changed with your household and your income as a whole. So quickly about Medicare Part C or Medicare Advantage plans. So these are actually offered by private companies that are approved by CMS. And what this does is that this just provides Part A and B coverage kind of as a whole as under one plan. But there's also caveats where it can offer additional coverage, which I've listed there for you. So things like vision or dental insurance, and then even some plans kind of group in your Medicare Part D or prescription drug coverage. So these are separate plans, typically have a little bit more cost associated with them in terms of their premiums and monthly costs for the patient, but it does group everything kind of as a whole under one plan. And again, the premiums that you pay can change each year and depending on your income. And then lastly, and most importantly, obviously from a pharmacy perspective, as the pharmacist giving the talk today, we're going to talk the most about Medicare Part D. And I feel like I can offer the most information about this. This is probably where I have most of my expertise. So again, why I focused a little bit more on this. So Medicare Part D is optional. It is offered to everyone, but it is not required. You can pay for these medications out of your own pocket as well. If you want Medicare Part D, though, you have to have Medicare Part A and B. So you can't just go right to Medicare Part D as a supplement. You have to have the other two parts as well. And again, the premiums that you pay for the drug plan will really depend. And I have a slide about that in a couple minutes. So here's just an example of a Medicare card. If you haven't seen one, the card is you'll have a unique number that's unique to you, and it is not your social security number. It has nothing to do with your social security number. So it helps kind of protect your overall identity. And this is a completely separate number, and it'll show what types of insurance coverage you have. So it'll show that you have Medicare Part A on there with the hospital, and then Medicare Part B listed as medical. It'll have either one of them or both if you have both. And then it'll also have the date that your coverage will begin. So just an example that you may see or may have seen in the past that I wanted to include there for you. So when we talk about Medicare Part D and prescription drug coverage, there's a lot of different ways that you can join. Again, already noting that you have to have Medicare Part A and B. So assuming that you've already signed up for those plans, how do we actually join Medicare Part D coverage? There's links in these slides. So moving forward, anytime you see these blue underlined words, if you are viewing the PowerPoint slides separately, so not in the video, you can actually click on that those blue words, and it'll open up a link directly to a website where all this information is available. So I tried to do that. And then at the end, I also have all of the websites and resources that I use to make these slides available as well. And I'm happy to share these slides separately if that's easier for people to view. So to join a plan, you can view the website that's available here under Medicare drug coverage. And there's a lot of different plans that you can choose from. And again, this is where it really is important to figure out what's going to be best for you based off of the prescriptions that you already have, or prescriptions that you know that you may be on at the time of kind of when the open enrollment is going to happen. There's also ways to complete a paper enrollment form that's available online, or you can call the numbers that are there or the plan specifically, because there's a lot of different plans that are built into Medicare Part D. But then the second link that I have here is before you make any decision as to what Medicare Part D coverage you're going to sign up for, is really to find out how that's going to work with your other drug coverage. So if you already have prescription drug coverage from, let's say, a different plan, whether it's a private insurance plan, whether it's from a employee plan, you want to make sure that they work together to kind of counter the cost of the medications as a whole. So the website that I have linked there for you is a really good resource to be able to determine if the plans will work together. And that kind of goes into that primary and secondary option that I discussed above to make sure that everything is going to work together. And you want to decipher kind of what's going to be your primary, what's going to be secondary to make sure that everything is paid for the correct way. So that's a good resource to be able to use to make sure that everything works together. But also, as I already mentioned, you want to make sure that you review the patient or the insurance formulary as well for that specific Medicare plan. As I mentioned, each plan will have its own formulary, and you want to determine if they have the prescriptions that you're already on and try to compare those costs for you. That's going to work kind of best for your income and your ability to pay for these medications. Every plan is going to be a little bit different, so make sure you're viewing those plans, and that's all on that website to be able to find kind of what the formulary is. And you can also call and speak to them to find out where your medications are in their formulary. But then you also have to pay attention to the tiers that are in the formulary. So every plan will place their drugs into different tiers. And I listed the tiers out there on the bottom. And each tier is associated with a different cost for the medication. So tier 1 is going to be your lowest payment for the drugs. They're kind of like your most generic, older medications that have been around for a long time that are probably the cheapest overall. Whereas if it's in a specialty tier on the bottom there, that's going to be your highest co-payments, usually high cost drugs for very specialized medications that are sometimes used. So you want to pay attention to where your medications are in the tiers of the plan itself, because this can really determine where you're going to pay for certain medications depending on the tier. Now, as a side piece of information, there is ability to move medications from different tiers, but that is a very specialized approach to the medication kind of plans and adjustments, and that takes someone that is more specialized and has a better ability than I do, or most pharmacists have the ability to do. So this really would require talking to your transplant team, talking to the insurance to see if any adjustments can be made to lower the overall cost. So for an example, if you have a medication like tacrolimus or your Prograf that's in tier 3 of your plan, there's a way that sometimes you can submit for an approval to put it into tier 2 so that it lowers your costs overall. But this is a very kind of challenging thing to do and not something that most patients can do on their own. It really requires talking to your transplant team. And then I talked a little bit about the premiums earlier for the plan being the monthly payment that you pay for the Medicare Part D coverage. And then really there's this chart that I have listed. This is from 2023 and it's based off of your income back a couple of years ago. So this is just an example, and this is not the whole table. I just included a little part of it. So it really depends on kind of what you file for your tax return, whether it's jointly or individually, or if it's married, and then kind of what you would pay in terms of your premium on the far right there. So just as an example, if you are married and you file a joint tax return and you make $194,000 or less as a couple, you would just pay your plan premium alone. So whatever that plan premium is that's listed on the website, that's what you would pay. Now, if you make more than that, so let's say you're in that bottom row there and you make like $300,000, you may have an additional cost to pay in addition to your plan premium. So just some things to be cognizant of about kind of what your total income is in your household and what that's going to relate to in terms of how much you pay for a specific plan. So all of, again, that information is available online to make sure you're reviewing kind of what medications are in your plan, but also what is going to be the cost for you. And then here comes that donut that we talked about a little bit earlier on, and I'm hoping that this can kind of explain the overall concept. And I thought it was funny that both donuts look the same, so I feel like it helps us, and maybe it'll make everyone hungry and want a donut after this. All right, so the donut hole explained, and you don't have to necessarily look at all the words on the bottom, but you can kind of just follow it along from the left to the right. So the first part of the whole process in terms of payment throughout the year is the deductible. So every time, if your plan has a deductible, and that's not a guarantee that every plan will, you'll pay that small deductible, whether it's $5 deductible, $10 deductible, it really just depends on the plan. And you'll slowly pay that up until a certain amount. So that's usually, for this example, is about $500, and every year it tends to go up a little bit, but you'll pay that small amount until you reach your max deductible. Once you pay that max deductible, then that's where you hit into your initial coverage, and that's really that first piece of the donut that you see. So you pay for those plans co-payments and co-insurances. So these are a little bit more in terms of the deductible, and you'll pay a little bit more for each of the different services and drugs that you're taking. You'll pay this once you and the insurance together. So the insurance is also paying their portion, you're paying your portion, once that meets a total amount of about $4,000 for this example, or $5,000. So every plan is going to be a little bit different in terms of that number specifically, but you're going to continue paying up until you hit that amount. That's where you're going to hit that coverage gap, or the donut hole. So that's the center of the donut, where you're going to have to pay 25% of drugs. And this can depend on whether it's a brand or generic drug. So for example, if you're paying 25% of the brand drug, basically the full price of that drug will still count toward that overall cost and kind of your overall out-of-pocket cost as a whole. So that's going to keep contributing to what you're paying into the plan, where if you're taking generic drugs, because they're a little bit cheaper, only a certain portion of those of that cost actually counting. So it really just depends. Not to say that you should switch to all brand names at this point. It's really just going to depend on how much you're contributing at that point. you're going to continue to pay that until you get out of that donut hole or that gap in coverage. And that's where you're going to hit the catastrophic coverage. And this is when it's reached once you've kind of hit that certain amount, and then your out-of-pocket costs become fairly minimal to potentially not even anything at all. So in this example, it's showing that once once you're spending and everything has kind of hit that like $7,400, which was probably an example from a couple of years ago, you're only going to pay a very small portion of drugs, which is listed there for you. And that'll be the same until it resets at the end of the year. So this can range, this can happen early on in your year. You could hit the catastrophic coverage in May, June, or it could happen really late in the year in December. If it does happen, once you're in the coverage gap, you'll notice that usually your cost of medications does go up. And then it really takes a few kind of refills or additional medication to get you out of that gap of coverage into the catastrophic phase where things will start to settle down. So if you notice when you're going to pick up your medications, and this is kind of what I wanted to highlight the most, is that the cost of medications may change throughout the year. And that's because of the donut hole concept. So if you notice that things have changed, it may just be because you've hit a different phase in your coverage. You can certainly ask about this. So most pharmacies are able to tell you if you've hit the coverage gap or if you're in a different phase of the care. So just ask, talk to your transplant team, and we can usually find out kind of where you are in terms of what level in the phase or in the plan you are and when that will end. Most of our team is able to do that and help kind of decipher that. And this is, again, kind of when you need to do your most research in terms of the plans that you're picking, because this can change depending on the plan that you have. So hopefully that was an easy example to follow and kind of follow along in terms of the different phases of the plan. But let me know if you have any questions about that. The other concepts that I'll talk about for Medicare, I'm going to make sure that we're staying on time for questions. So Medicare drug plans have a variety of different network pharmacies that they use. So typically, if your plan requires a specific pharmacy, they will note that, and usually your transplant team can tell you that. This is just going to give you the best prices for the prescriptions that you have if you fill with their network pharmacies. And then they typically offer 2 to 3 months supply. So you can get a little bit longer supplies at home or even a mail order program. So these examples of this are like CVS Caremark. That's a fairly common one that certain insurance providers actually do require. And then lastly, for Medicare, there are a lot of different options to lower your drug costs. So again, these blue links all will refer you to different websites that'll help kind of compare Medicare drug coverage. So again, finding out what plan is going to be best for you. Check if your company offers help. And we'll talk about kind of ways that companies can help. I have a slide specific to that in a few slides. And then there's also this program called the Extra Help Program. And this just helps people with limited income pay for their Medicare Part D costs. And then there's ways that you can automatically qualify as well. So if that's something that you feel like you may qualify for, or you feel like you have struggles with paying for your Medicare Part D, definitely use that link to try to see if there's any ways that can be helped. All right, so I talked the most about Medicare, and then I'll switch gears to Medicaid and a few other additional slides. I don't have as much information as Medicaid, as there's not as many kind of details about it. So Medicare is more of a federal or state program that helps cover costs for people with limited income or resources. Because this is a federal program, it does have general rules that all states have to follow, but then each state has its own program. So if you live in the state of Maryland, you're going to hear Maryland Medicaid, and that's its own state program. And then to be eligible and to have benefits, they really vary from state to state. So the overall rules are the same, but each state kind of makes their own program itself. What's nice about Medicaid is there's typically no cost for the medical expenses that are covered. You have a small copayment for certain things, but generally the cost from the patient, because this is patients with limited income, the cost to you as the patient is fairly low. To be eligible, there's a variety of different patients that are included. So if you're pregnant, if you have a child or a teenager with limited income, or if you're greater than 65 years old, if you have a vision disorder, or if you are disabled. And if you're deemed disabled, you would qualify for Medicaid. To apply, again, using the link that I provided, you can do it directly with your state. There's a health insurance marketplace that you can visit, or you can just go to healthcare.gov to kind of make an account and apply online. And then again, there's always a phone option for patients if you'd rather just call and not use the internet. So a variety of different ways that you can try to apply if you feel that you would be eligible for Medicaid. Specifically for Maryland Medicaid, what I want to point out again, that open enrollment period is a little bit different. So it started a couple of days ago in November 1st, and this goes all the way till January 15th. But then if you have a life event kind of throughout the year that you feel that you would then be qualified for Medicaid, you can enroll outside of this time. What I did want to point out that someone that I work with very closely thought was very important is that this recently changed for patients that do have Maryland Medicaid, is that it is not automatically renewed anymore. This has changed over the past couple of years since COVID. So the renewals take place over the 12-month period over the course of the year. And what you would need to do is make sure that if you have Maryland Medicaid, your contact information with them is updated so that they can reach out to you and send the appropriate forms. You will receive a notification in the mail that you're up for renewal, and then you have 45 days to renew that coverage or enroll in a different plan, whether that's private insurance or Medicare if you now qualify for Medicare. So that's important that I wanted to highlight, to just look out for that if you feel that you have Maryland Medicaid and want to continue with Maryland Medicaid, to make sure that you are making sure it's renewed. And then I also wanted to point out that there's other special programs that are available for Medicaid patients. So each state program has a special program for patients with end-stage renal disease or kidney disease specifically. And I listed the states that are at least in the tri-state area. There are more, so if you live in a different state and are curious about it, you can certainly Google Medicaid special programs by your state. I listed the Maryland, Delaware, and Pennsylvania ones there for you. And really what these are available for is to help supplement primary insurance, to help with some of those additional costs. And anyone can apply to these if you feel that you need additional assistance and have kidney disease. All right, so I talked about Medicare and Medicaid, and I'm just going to briefly talk about private insurance. And unfortunately, I'm not able to talk a lot about private insurance. And the reason is that there are many, many different options available. So these are often provided by your various employers or other organizations. They can be on a group basis or an individual basis. There's so many different caveats. And I listed some examples of different private insurance companies that are available. But as many of you know and have probably seen throughout the course of your transplant or even prior to transplant, there are many different options. And really all of them vary by their cost and what services they have available. So I would need to do a presentation probably on each individual program, which would take much more time than an hour. So I tried to just keep it kind of brief, that this is an option, it's available. There are ways to reach out to these companies to make sure if this is something that you would like to sign up for. But that's why I wanted to kind of spend the most time on Medicare and Medicaid, as these are the more common ones. And then lastly, in terms of insurance overall, I did want to touch on patient assistance. I mentioned this briefly prior. There are a variety of different programs that are available that you may hear of and should definitely think about if you have high cost medications. So patient assistance programs, or PAPs, you'll hear these talked about. What these are is they're directly from the drug manufacturers themselves. They provide low cost or free product to low income patients typically. So you do have to meet a certain threshold. And this is to help kind of augment or decrease the prescription drug coverage. The best way to find out if these are available is to check directly with the manufacturer or your transplant team to see if there's an option for a patient assistance program for the medication that you're on. These programs kind of come up and disappear fairly often. A big example of this that patients may be aware of is the Valgan Cyclovir Valsite. There was a fairly large patient assistance program for many years that just recently closed. So they no longer offer that. So it does change. If you're in a program, we can certainly find ways to help you when that program ends, but it's definitely something to look into and ask your team about. And then the other one is copay cards. So a lot of manufacturers also offer these copay cards to help kind of lower your overall like out-of-pocket drug costs. So an example of this is a medication, a blood thinner called Eliquis or apixaban. Patients may have heard of this. This is a medication that has a copay card that is available for patients that have that lower income and aren't able to afford it. The best resource that's available to check for these copay cards is on GoodRx, which is a very good resource for kind of lower drug costs overall. And the link is provided there for you. But the one point I did want to highlight here that's in bold there is that if you do have Medicare, Medicare Part D specifically for your drug coverage, they do not offer copay cards. They are not able to use copay cards on top of Medicare. So just something to be aware of. If you ever are trying to use a copay card and have Medicare, you will get denied. So just to not be surprised about that. All right, so last slide here, just some key points. So of course, as a transplant pharmacist, your medications after transplant are extremely important. You want to adhere to all team recommendations for the best outcomes. We will obviously pay close attention to all the medications that you're on, and it's always that balance that we want to try to make sure everything is going as smooth as possible. We know that there are many different insurance options available. I tried to highlight the ones that I felt are the most common, tried to give the information that I felt was the most important to make kind of best decisions for your care after transplant. But really the best thing to do is to find out which plan works best for you. There is not a one-size-fits-all approach. Every patient is different. All medications are different, and the income that you have exposed to you and ability to pay for these medications is different. So do your homework, ask questions to the team. We can certainly provide resources and help you make that decision that's going to be best for you. And then if you ever have questions, feel free, of course, to contact your transplant team. If you're transplanted at University of Maryland, where I work, we have a very large network of coordinators that can get a hold of us as the transplant pharmacy team. And we are very fortunate to have a pharmacy technician that is a billing coordinator that does a lot of this stuff for us and is an expert in the topic. She helped me with providing some of this information. So definitely shout out to her. And if you have questions for us, just please reach out. As I mentioned, all of my references are here. So these are good resources to use. Medicare Interactive is apparently a very great website for patients. It's very user-friendly. That's that fourth one down. But even Medicare.gov and even some of the Maryland Medicaid ones are also very useful and very user-friendly if you have additional information that you want. And at this point, I will turn it over to questions. I see that there are a few questions in the chat already, so I'm going to pull that up. And I will try to get through as many as I can. We have about 10 minutes. And anything that I don't answer, if I can't answer, I will try to get an answer for you. So the first question I have on here is, I am 1 year post-transplant. How long should I hold on to my prescriptions I am no longer using? For example, Bactrim, I stopped, but I have an entire month of Bactrim left. Should I hold on to it until expiration or recycle it now? Very good question. We always tell people to hold on to it at least until it expires. So typically prescriptions are good for 1 year from the time they leave the pharmacy. Just hold on to it, especially something like Bactrim, not as common, but let's say it's even something like your tacrolimus and a dose has changed. You never know when that dose may change again, or you may need to go back on something. Obviously, we hope that your transplant course goes really smoothly and you don't need to go back on any medications that are stopped. But unfortunately, that does happen. So hold on to them. And then after they expire, then it's the best time to recycle them. And you can either bring them back to the pharmacies or take back. There's programs that take medications back. Some of them are able to be thrown away, but always better to just hold on to them for the time being. Next one is about 7 years after a liver and kidney transplant. They're just answering, just to hold on to them, hospitalized. And I couldn't agree more with the answer that was given. So I should have just read a little bit further, and I could have skipped that one. The experts are the patients, that's for sure. Is there any one place that lists all the copay assistance cards? That is a great question. The best place to check would be on that GoodRx website. they have a lot of different resources that are available to find out what copay cards are available. They have, I don't know if it's specifically a list of all of the ones available, but if you type in the type of medication that you're taking or looking for, you can certainly try to find that way. Another way to find out if there's a copay card available is simply just Googling the medication that you're on and just type in copay card right after and see what comes up. It'll typically bring you to the manufacturer's website and you can play around and find if anything's available. The other way that's always helpful, and some patients would prefer, just actually Google the medication, find out what the manufacturer is, and just call the manufacturer directly. And they can typically, they have medical science liaisons, and they have people that work for them directly to help with patient assistance. And then the next question is, does the pharmacy coverage with Advantage plans include the drug costs covered in Part B? Yes, so good question. So if you have a Medicare Advantage plan that is A, B, and then you also have Medicare Part D on top of that, that is included in your Advantage plan, they should still bill your immunosuppressive medications the same way. So again, I would advise you probably to just talk to the pharmacy to make sure that you are being billed correctly and making sure that it's going through Medicare Part B. But I'm almost positive that it's still run the same way as a general Medicare program. So good question. Another question, what resource do we have when our doctors want us on a different med? So example, Zortress or everolimus instead of tacrolimus, instead of severe tremors from sacrolimus, but our private insurance company says they won't cover it. Yeah, so this is unfortunately one of the biggest barriers that we have in all of our transplant population is when we want to switch a medication because of a side effect. So for this example, if you had really bad tremors to tacrolimus and your provider wanted to switch you to everolimus or Zortress, which is one of those mTOR inhibitors I talked about at the bottom of the table, the best thing that you can do is talk to your transplant team and see if you can appeal it with the insurance company. Typically, every time you get a denial from an insurance company saying, no, we will not cover the cost of this medication, typically what you can do is submit for an appeal. You may have to provide additional documentation. And by you, I mean the provider and the transplant team. So for example, as a team at the University of Maryland, we have written letters that we kind of use as an example, and we just type in the patient's name and the specific symptoms that they're having, and we send that to the provider, the insurance providers, to see if they'll appeal the denial based off of specific symptoms. The other way that if that doesn't work, there are other medications that they can potentially switch you to because of tremors. So for example, and again, I don't know where you were transplanted or who your provider is, everyone has different policies and procedures, but things like Invarsys is one of the newer tacrolimus formulations that can help with some of those tremors, and insurances have started to cover those a little bit more frequently because of tremors specifically to the original formulation. So there's other examples. Definitely just talk to your transplant team, see if there's an appeal that can be done, see if they can submit some additional documentation to try to prove to the insurance why the other medication is needed. Sometimes it's also as simple as they just sent for the wrong medication. So maybe they just need to try for the generic medication, not Zortress, just try to send for everolimus as the generic and see if that'll be covered as well. The next question, when do vitamins like calcium expire? Check your medication bottle. Every bottle should have an expiration date. I don't know the name or the expiration for every one off the top of my head. I definitely don't have that good of a memory, but check your bottle. They definitely will say it on the bottle. And if you have any other questions, you can bring it to the pharmacy and they can tell you as well. And
well, Ian, that's great. Kathy already commented that it was a great meeting. It's so much information, and it's almost unfair to ask you to talk on this kind of topic because, like you said, you could go on forever with all the different insurances. But I think you did a great job kind of getting to the real key and core topics and coverage that people need to understand. So thank you for delving into that for us.
And I'd like to thank you,
Absolutely.
Ian. I'd like to thank you very much, Ian, for attending the meeting today and giving us a hand with this topic, along with everybody else that joined in this morning. It was quite a crew. I want to remind everyone, Ian made mention earlier about having a copy of his outline today. You will find a copy of it on our website at www.triomaryland.org. Underneath the speaker notes, you will find Ian's conversation today along with his notes. And you'll also find all our other meetings that we've had over the last couple of years on there also. So if you're looking for those references, there they are. I also want to remind you on our website, you will find advance notices of our upcoming meetings. So you might want to keep an eye on that to start off 2024. But as I said a little bit earlier today, we will not be having a Zoom meeting in December. We're going to allow everyone to enjoy their holidays without us. January will be an in-person meeting at the Infinite Legacy Foundation here in Baltimore, Maryland. So if you're in the neighborhood and you're on our list, please stop by and join us for a cup of coffee and cake. Otherwise, we'll see you in February at our next Zoom meeting. We want to thank everyone so much for all this, all your attendance this year and making Trio a successful commodity. And we want to wish you all a very nice holiday. So if there's anything else that you need, please get in touch with us. Otherwise, thanks again, Ian. We appreciate you attending today and along with everybody else.
Thanks, Ian.
Absolutely. Thank you again for having me.
Everyone have a great weekend. I don't see a lot of faces. I see a lot of names, but enjoy the holiday season and say prayers that my caregiver here, as I'm recuperating, can hang in there and continue to take excellent care of me. So.
Okay, folks, thank you very much.
Bye-bye. Bye.
Bye, everyone.